Hi, and welcome to another week of psychopharmacology. This week, we're going to talk about chapter 9, which is about opiates. So opiates are sedative drugs that block pain and also induce euphoria. So as a class of drugs, they are very useful. Can you imagine having surgery and not having morphine after the surgery to block pain? So we need these drugs very badly for medical treatment. But at the same time, the high that these drugs cause can really lead to serious addiction. And all I need to tell you is that this class of drugs includes heroin. And you can probably imagine that heroin is one of those drugs that has caused so many people to develop very serious dependence symptoms and syndromes from. And in many cases, needing lifelong treatment for addiction. So on the one side, incredibly useful drugs. On the other side, also drugs that could cause all kinds of problems. Opium comes from a plant. And so morphine is the principal alkaloid that is found in opium. And heroin is the purified version of morphine. In this class of drugs, we also have some semi-synthetic opiates. Codeine might be one that you recognize. Oxycontin, another one, or oxycodone is another example, Vicodin. And so a lot of times these drugs are used as prescription medications for serious pain. But then again, because of the high that they cause, they're often diverted for illicit use. So here's a picture of the poppy plant, the opium poppy. Humans have used this plant for thousands of years because all you need to do is take that seed pod, the center of the flower, there's a little pod, and if you just score it with a knife, you could actually get the sap out of it, and that would be the part of the plant that has the active compound. So people discovered that, humans discovered that even thousands of years ago, and I detail the history a little bit more in the chapter. And does this plant grow everywhere easily? No, not really. There are certain areas of the world. So Afghanistan, there's a picture from a field of poppy plants in Afghanistan. And so certain parts of the world, the climate, the soil conditions are well suited for growing this plant. Heroin comes from chemically processing the morphine. So morphine being a white odorless powder. And controlling where heroin comes from a lot of times involves us going into countries like Afghanistan to try and encourage farmers to grow something else instead of the poppy plant. And in these countries, a lot of times the growing conditions are really quite poor. The plant actually grows in very poor conditions, but substituting a different agricultural crop for it is challenging. And so you have these very poor countries, and there isn't a lot of alternatives of things could be grown so that people can support themselves. And I should mention too, like the farmer is not making all the money that is coming from the illicit drug trade compared to other people who are trafficking. So in the United States, heroin does not have any medical uses. It's considered Schedule 1. Schedule 2 has morphine in it, opium, codeine, oxycodone, because there's very good reasons to use it for medical reasons, but also very serious concerns about dependence. Then there are other drugs like Robitussin contains some codeine in it, and Robitussin AC would contain codeine. And so that would be like Schedule 5 because you would want to be careful with that substance, but not nearly so concerning with the dependence. So there are, in the textbook, there's on table 9-1, there's a bunch of different medical uses for opiates, and they are used for acute pain and for chronic pain. When people are in pain, if you've ever had the experience of being in serious pain, like you had surgery, you know that you will be still aware of the pain, but it is much less aversive and less emotional. The suffering that you feel when you're in pain is much less emotional. historically, we used it more liberally for pain treatment, but then we've had such serious problems with addiction that physicians have become much more careful about looking at these drugs and what could we use instead that wouldn't be so worrisome for the risk of dependence. The other thing that's sort of tricky when you treat pain is that pain is horribly aversive. But it's also difficult to determine when someone is in pain because to a certain degree, you rely on self-report. So unlike other medical symptoms where you can see someone's blood pressure rising, the pain is the self-reported. Medical uses, you also would, for example, use opiates in cases of extreme diarrhea because it does cause constipation. And so if someone has extreme diarrhea, that's would be a good situation to use it. So routes of administration depend on how the person is using the drug, whether for medical reasons or they're abusing it. So for medical reasons, it might be oral in a pill form. That would be safe because it's slow absorption into the system. Transdermal patches for someone who has chronic pain, the slow absorption through the skin might be another pathway. There's inhalation, intranasal injection. A lot of times that's more common with the illicit use, and injection is associated with all kinds of problems. Obviously, you could have HIV infection or any other sort of disease transmission that comes with needles being shared. Needle exchange programs will decrease this risk, but when you are repeatedly injecting yourself over and over again as a individual who's a substance abuser, then there are going to be health consequences in some cases that comes from that over time. So what do people report in the short term, the acute effects when they're using opiates? The first thing is they'll feel the sedative effects like decreased activity. They'll feel a little like sedated, sleepy, decreased signs of pain. Obviously, you will immediately see as if you have a patient who's in a lot of pain, they won't be grimacing or moaning quite to the same degree once the pain medication starts to become active in the system. As a sedative drug, cognition is going to be impaired, speech is going to be slurred. A lot of the things that we saw in the alcohol chapter and the last chapter, the sedative effects look similar. Confusion, poor judgment, and all of these are the immediate effects. Subjectively, people will say they feel more relaxed, increased sense of well-being, reduced tension, anxiety, or aggression. They will feel high at the higher doses, and particularly if the route of administration results in fast onset of the drug effect, such as with injection or smoking. Other things you can see, so you can see the effects on the body where pain perception is reduced, respiration is slowed and depressed, and breathing becomes more shallow. So particularly for individuals who are in a great deal of pain, this is something that would be watched carefully in maybe a hospital setting because you want to be careful. So for example, end-stage cancer treatment, sometimes if someone is end-stage cancer, they're in a tremendous amount of pain. And if you give too much morphine, their breathing will start to get altered. Skin can be itchy, pupils get constricted. So this is what someone will look for in an overdose situation, to look at the pupils. The little black part of the eye gets really tiny. You know, sometimes you'll see nausea, vomiting, and constipation. Lethal dose. Opiates can easily lead to overdose and death. And so this is the risk with treating someone medically, but this is also the risk when people use them as a drug of abuse. In either case, too high of doses can lead to an overdose because the breathing stops, so the suppression of respiration. In a case of overdose, it can be treated with an opiate antagonist like naloxone, like Narcan. And so this is a harm reduction technique, harm reduction method that is used by distributing this to users. So if, for example, they take too much of the substance or they're around somebody else who's using too much, you could use the antagonist to help that person so they don't die. Overdose is more likely when opiates are mixed with other drugs. And a lot of times, especially people who are dependent on drugs, they don't always use one at a time. I think I mentioned this in previous chapters that it's very common for substance abusers to use multiple drugs at a time. And so alcohol with opiates would be a terrible combination because they're both sedatives. Oftentimes users will also mix a stimulant like cocaine with heroin. And so in many cases, the stimulant blocks the sedative effects, the perception of sedation. And so they don't realize how much heroin they're taking, and that can be incredibly dangerous. So if people have to use opiates repeatedly and it becomes chronic, whether it's for medical reasons or for the use of the substance in a dependent situation, dependence is always a concern. So even in medical reasons, you are completely justified in using the morphine or the oxycodone for very serious pain. We do need to be concerned about the dependence. It's associated with greater risk of early death by accident, by overdose. Injections are associated with infections in dependent users who are using it as a drug of abuse. When you repeatedly use opiates, it can actually result in increased sensitivity to pain once that drug is taken away. So that can be really tricky for people. So if they, for example, someone has a really serious like back pain problem that requires surgery or something like that, and until they can get the surgery, they continue to take opiates, the dose keeps going up because they're getting tolerant to it. And then if they suddenly have to stop the medication, then they're in extreme pain because they're extremely sensitive to pain. Dependent users, same thing. When they go into treatment, once they get off the heroin, everything hurts. They're so sensitive to pain. And so that's something that is really difficult to deal with. It can cause impotence and weight loss and chronic constipation. Some studies have found that users have neurocognitive deficits where they have trouble with their memory or problem solving. And then risk of infections like HIV coming from sharing needles, things like that are always a health concern. Now with tolerance does develop extremely quickly. Tolerance does develop to some of the euphoria, and the respiratory suppression, the slow, shallow breathing. Chronic users, because they're developing significant tolerance, they sometimes start to use amounts that would cause death in the casual user. And we've even seen this in studies with rats, right? That the environmental cues prompt you to know that the drug is coming. And so users can rely on those cues. They don't realize they're relying on the cues, but even a rat in a study is relying on environmental cues. And so, you know, that tends to be a big concern if you put someone in a new environment, or, you know, say they go into treatment, they're not using, and then they come out again, and then they use their typical dose, and then they overdose because the tolerance has reversed with abstinence. No tolerance occurs to the constipation, which is a challenge for especially medical use of you know, these various classes of drugs. And biological and learning mechanisms are involved in the tolerance. So both things are important. The environmental cues are important as part of learning. Biological things that are changing in the brain that adapt to the drug being on board are also occurring. Physical dependence is something that will occur very rapidly. Within 1 week of regular use, you're going to be able to see physical dependence. And withdrawal begins within 6 hours. So you stop using for 6 hours and already you'll start to see evidence of withdrawal symptoms. And the withdrawal symptoms look like horrible flu-like symptoms. So flu-like symptoms, also craving, pain, nausea, tremors, all kinds of symptoms like that look like flu, pupil dilation, sweating, increased heart rate, blood pressure, you know, spastic arm and leg movements, yawning. All of these things in many cases are not life-threatening, but boy, are they extremely aversive, very, very unpleasant. when you think about how the drug is acting in the brain, the opiate receptor and endorphins were discovered in the 1970s. And endorphins are your natural substances in the brain that are involved in pain perception. So opiates, as a class of drugs, are going to fit into those endorphin receptors and block pain by inhibiting neurotransmitter release. We need this system in our brain because, it's the fundamental part of the fight or flight response, right? So imagine you're living in caveman times and you've been attacked by a bear. It doesn't really help to sit there and cry over your injury. You need something that immediately blocks pain from your gushing wound in your arm so you can run away and get out of there and fight the bear until you can survive. You can feel the pain later, but in that moment, you need a system that will block the pain. So this system is so fundamental to survival, and we rely on it. It's important that these drugs are available, but that high, the high that you feel and the pain blocking that you feel goes back to that fight or flight response. It makes sense to have an energy rush, a blocking of pain if you have to escape some sort of dangerous situation. All vertebrate and invertebrate animals have endorphins. In fact, as an undergraduate student, I did research on snails on this very topic area. So we were looking at the different types of endorphin receptors in the land snail, the mu, delta, and kappa receptors. It sounds a bit like a sorority or fraternity or something like that, but the morphine binds with the mu receptor. So we were testing this new compound to see if it would block pain perception in the snail. And we were comparing it to morphine. And you can tell, like a snail, if it lays on a hot surface, it will lift up its little snail head and lift off the hot surface if it doesn't like the warm surface. And if you block pain, the snail will stay on the warm surface longer. So my job was to sit there with like the stopwatch and see how long the snail would stay there, depending on the type of treatment we were doing. So not every piece of research in psychopharmacology is human stuff. Sometimes it's the slimy snails that you get your start in. Okay, so treatment. For people who are dependent on opiates, as I mentioned, withdrawal is extremely aversive. It can also last for a really long time, especially this abstinence syndrome where people feel extreme amounts of craving for the drug and they are very depressed. That can last up to 6 months. And so it leads to relapse. And so having some sort of medication, a pharmacological approach, is really critical to helping people who have, for example, heroin addiction. So you can use different things. Substitution therapies are usually very helpful. Methadone has been around since the 60s. People who use methadone tend to be very well maintained on it. They tend to lead normal lives. They don't commit crimes. A lot of this is in the textbook in a lot more detail, but there's very good scientific evidence that substitution therapies are an effective way to help people get off heroin. Other drugs that have been developed, like Suboxone is a good example. Sometimes someone who hasn't used quite as much might do really well on Suboxone. Someone who's a really lengthy, very long history with a heroin abuse might do better on methadone. So depending on when the person goes into treatment, it's a good idea to assess all kinds of things about their dependence history to see what treatment might work better for that person. When people are treated, relapse is common. It's normal. It's part of the process. A lot of times, sometimes people will need lifelong substitution therapy. Medication is needed for the entire lifetime, sometimes not, depending on the person. In other countries, not the United States, but in other countries, there's actually supervised heroin injection centers where people are provided with heroin, with the idea being that, as long as we can maintain the person on heroin in a safe dose level, they will be normal contributing members of society and they won't commit crimes and things like that. So that is not here. But, you know, different countries have approached this dependence problem differently. It certainly is the most serious dependence problem, and people who become dependent on heroin really struggle. And so different countries have come up with different ways to help people. Now, just to finish up, one of the things the last bit of thing I wanted to mention is that we do struggle with treating people effectively with pain in all medical conditions, because again, like I said, it is difficult to know how much somebody is in pain. You're kind of asking them how they feel, and people have different levels of pain tolerance. And a lot of times post-operative pain is undertreated. Older people are undertreated for pain, and physicians fear addiction. And so there are very good studies that suggest that when people are in acute, very serious pain, and you can induce this even in the lab, people tend not to get high. So there's a picture on this slide. This woman is sticking her arm in an ice bucket. And if you have ever done that before, you know that once you leave your arm in ice water, it gets really painful very quickly. And so you can see how people respond in these situations. And if you give people morphine in that kind of situation, they tend not to report feeling very high. And they also, you know, they just feel like they can keep their arm in the ice water longer, as opposed to, you know, someone who's in the control condition where they're just exposing their arm to lukewarm water. So what that means is that we need to carefully assess how pain is experienced by people, get better at assessing pain in all age levels, all different people in society, from children up to the elderly. And we're looking for more pain treatments. And in the next chapter, when we talk about marijuana, we'll talk about how that the medical uses of Marinol, for example, can also help people with pain, but using a different neurotransmitter system that is less addictive. And that is the end of this lecture.